my name is Nancy Richard. The topic is Ribavirin for chronic hepatitis E virus infection in transplant recipients. And in definition, hepatitis E is a liver disease caused by infection with a virus known as hepatitis E virus. The virus has at least 4 different types. Genotypes 1, 2, 3, and 4. And application in medicine, the hepatitis E virus is transmitted mainly through the fecal contamination of a very large proportion of clinical cases with the disease.
Hepatitis E is RNA virus, spread by the fecal-oral route. Incubation period 3 to 8 weeks. Common in Central and Southeast Asia, North and West Africa, and in Mexico. Causes a similar disease to hepatitis A, but carries a significant mortality, about 20% during pregnancy. In general, hepatitis E is a self-limiting viral infection followed by recovery. Prolonged viremia or fetal shedding are unusual. In acute infection, IgM antibodies to hepatitis E virus are positive. Does not usually cause chronic disease. A vaccine is currently in development, but is not yet in widespread use. Thank you for watching. For more video.
Pros and cons, in rare case, acute hepatitis E can be severe and result in fulminant hepatitis disease. Patients are at risk of death. Fulminant hepatitis occurs more frequently when hepatitis E occurs during a pregnancy.
What we have learned about hepatitis E diagnostics. Our first patient is Hannah. She feels sick and had to vomit at home. She's feverish and her skin has a yellowish color. Her symptoms started 1 week ago. 4 weeks ago, she came back from Mexico when she visited family. Obviously, we think about hepatitis. Let's order lab tests. In Hannah's lab report, we can see that her liver enzyme function is significantly elevated. Furthermore, her hepatitis E tests are positive. Hepatitis E RNA is also detectable. So what's your diagnosis? Hannah has no history of immunosuppression. So let's take a look back at the graphic dealing with immunocompetent patients. Her ALT is very high, which signifies serious liver damage. Anti-HEV IgM and IgG are both positive, and we could detect RNA in Hannah's stool. Based on these results, we can conclude that Hannah is most likely in the early phase after infection. So Hannah is suffering from an acute hepatitis E infection. Let's see our next patient. Our second patient is Pete. He suffers from abdominal pain of recent onset. In the lab report, we can already see elevated liver enzymes. Pete received a lung transplant 8 years ago. Currently, he is on immunosuppressive therapy. Furthermore, he tells us that he's a passionate hunter. Based on Pete's history, we include hepatitis E screening in our lab report. We can see that his liver enzyme function is significantly elevated. His anti-HEV antibodies are negative. However, the lab detected HEV RNA in Pete's stool. What does that mean? Since we know that Pete is taking immunosuppressive medication, we should consider this in interpreting his lab results. We know that immunocompromised patients can have problems producing antibodies to the virus. So in Pete's case, it is essential to measure RNA. His lab report shows elevated ALT levels as a sign of liver damage, but negative antibody tests. However, there is RNA detectable in his stool. Pete is suffering from an active, ongoing HEV infection. Based on the laboratory findings, we cannot determine when Pete was infected. It may have been recently or more than 6 months ago. However, it is not important to know that. What is important is that Pete gets appropriate treatment and follow-ups. Congratulations! Now you can handle hepatitis E lab results.
Development Mastery video.
In Ecuador, every year there are an estimated 20 million virus hepatitis E infection worldwide and leading to an estimated 3.3 million symptomatic cases of hepatitis E. In conclusion, is Ribavirin as monotherapy may be effective in treating chronic and virus hepatitis E and infection.
Hey, thank you for watching Medicosis Perfectionalis. Hepatitis E mnemonic. The E mnemonic, also known as the EU mnemonic, coming up. Hepatitis E. Remember, EU. It causes jaundice in the Far East, Egypt, and by Egypt I mean Africa. And by the way, Egypt is my home country. India, Central America, contaminated water, ew, contaminated is ew, undercooked seafood. Sometimes some genotypes of Hep E are endemic in the swine. So undercooked pork can cause Hep E, hepatitis. So swine, pigs eat everything, including garbage and worms, so that's ew. No offense to pigs. Fecal-oral route of transmission. Sometimes it's common in pregnancy, and when it comes to pregnant women, it's fulminant. Fulminant means massive necrosis, which can lead to failure. Ew. There is marked cholestasis in hepatitis E. Mostly it's acute. In these countries, sometimes it's the most common cause of acute viral hepatitis. Wow. But, however, it also can be chronic, such as patient with HIV or patient with immunosuppression. Some textbooks, including Harrison's, which is my favorite book, I will link it in the description, it regards Hep E as an opportunistic infection for people with HIV. So, acute will have IgM antibodies in the blood, and chronic will have anti-HEV IgG. It's very similar to Hep A on electron microscopy. To remember that A and E are both vowels. Okay? Remember Hep D was dependent on whom? On Hep B. So you can draw D like this, and you have B, and A and E are vowels, so they go together, and these go together. Anyways, so that's it. Now you know everything you need to know about hepatitis E. But wait, there is...
Another topic is immunotherapy in renal cells carcinoma. On definition, the immune evasion is a mark of cancer, one of the many pathways through which cancer can progress and avoiding the immune system and the immune destruction. Unfortunately, nowadays these can be targeted with some novel drugs. The innate immune system, which used to raise rapid response through pattern recognition, increase in cytokine, and this will mostly happen through phagocytosis, which are macrophages and natural killer cells and the adaptive immune system. In application in medicine, and the cells that are involved in tumor reaction to many T lymphocytes. The antigen presenting cells that are reorganized by a CD4 plus does the immune synapses.
The one that people are very excited about is the Emotion 151 that we just heard from Dr. Bob Moser. And this is a phase 3 randomized trial that looks at bevacizumab with atezolizumab versus sunitinib in a phase 3 setting for advanced metastatic clear cell kidney cancer. Let me just give you a little background on how we treat kidney cancers or advanced kidney cancers. So certainly there has been a lot of landscape changes. In the past, if we go back even a decade ago, we really did not have a lot of systemic therapies to offer. But now we have VEGF inhibitors, so these are what we call the TKIs. And certainly we have the immunotherapy drugs, but mostly for second line right now. So with the advent of these trial, the landscape of treatment is really changing. So in this phase 3 trial, though, what they saw was a phenomenal and very compelling improvement in the progression-free survival. The overall survival is yet immature, but we are seeing that there is two co-primary endpoints. One is progression-free survival in patients who are PD-L1 positive, and in this population there was about 40% of them, as well as an intent-to-treat population. And what they found was the PFS, for instance, for the combined therapy is in the order of 11.2 months, compared to only about 7 months for the sunitinib arm. So these are compelling data. And in terms of toxicity, actually there's not a whole lot that it's unexpected, if you will. So I think it's a fairly tolerable regimen. So I think moving forward, this is a great candidate. Perhaps, we will be seeing more this year. I think it's rapidly evolving. And the trial I just mentioned, the Emotion trial, is but one of them. Last year at ESMO, we heard about the Checkmate 214 trial, which looked at the combination of nivolumab and ipilimumab versus, again, sunitinib, and that was also a positive trial. So we are starting to see now these combination IO drugs that are pretty soon going to be changing the landscape of treatment, because right now IO therapy has largely been second-line therapy with nivolumab. So I think we are starting to see these agents move up, and not just maybe single agents, but in combination.
And pros and cons. The pros is the interaction the T cell receptor has two main transmembrane components. The number one is CBA plus, consisting of two highly variable alpha and beta subunits, and they will be responsibility for the specificity of the T cell interaction for a specific antigen. The number two is the CD3, a molecule that encodes a transmembrane protein complex that will be responsibility to replace surface and signal to the intracellular. And cause tumor invasion of immune surveillance. This occurs when the intracellular to suppressor mechanisms have unfailed. In sites applied in Ecuador, destruction of tumor cells to targeted to CD28 plus was done in fundamental research, but it is probability to potent receptor and the immune side effects we are too significant to be using in clinic.
The CT scan of the abdomen and pelvis performed with intravenous contrast. We'll start at the lung bases and scroll inferiorly. As you scroll inferiorly, we can see that there is an exophytic, predominantly solid mass arising from the upper pole of the left kidney, compatible with a renal cell neoplasm. There is an additional mass in the left kidney seen more inferiorly. However, if we observe its density value, and in fact measure its density value by putting a Hounsfield unit over this, we'll see that it measures simple fluid, somewhere between minus 20 and 20 Hounsfield units, thus indicating that it reflects a simple cyst. As we scroll through the right kidney, we can see that in the interpolar to lower pole region, there's another simple cyst, However, there are no solid masses arising from the right kidney to suggest a renal neoplasm. On these images, we can observe some of the vasculature associated with the kidneys. On this image, this is the aorta, this is the IVC. As you scroll downwards, we can start to see the left renal vein, and notice how the left renal vein travels anterior to the abdominal aorta as it joins the IVC. We can also start to see both renal arteries, right side and left side, and we can follow these vessels to the kidneys. This vessel over here, we can follow this as we scroll upwards again. We can also see the collecting systems which join to form the renal pelvis, and subsequently the ureters as they course inferiorly to the pelvis. This is a coronal CT scan of the same case. We're going to be scrolling from posteriorly to anteriorly in this case. So as we go from posterior to anterior, the posterior-most structures, we're going to start to see the spine, some of the ribs, some of the bones, and then we'll start to see the kidneys. Once again, you can see an exophytic, predominantly solid mass arising from the upper pole of the left kidney, compatible with a renal cell neoplasm. On this image, you can see some of the left collecting systems, which will join to form the left renal pelvis. As we scroll, we can also see the left renal artery, as well as the left renal vein, which drains into the inferior vena cava.
And in conclusion, is the immunotherapy neural cell carcinoma. And the first point is spontaneous regression of metastasis after nephrectomy, less than 1%, and percent of immune cell and cytotoxic T cells in resected tumor. Identification of tumor-associated 8G down count servers at MHC. And another point is that initial immunotherapy experience is interleukin 2, interferon, and stem cell transplantation. Thank you.